I'm going to discuss a clinical case we had at the hospital, which I think is relevant for understanding the manifestations of spondyloarthritis, axial, how we diagnosed it, the test we ordered, and the treatment we prescribed. It's about a 38-year-old man with no relevant medical history, except that he smoked until 2 years ago. He was quite active and worked remotely as an IT specialist. He comes to our clinic due to lower back pain with inflammatory characteristics, accompanied by about 30 minutes of morning stiffness, and it disrupted his sleep at night. He said this had been happening continuously for the past 10 months, but when we dug a little deeper, he told us that for the past 2 to 3 years, he had been experiencing lower back pain, which he attributed to his job since he spends 8-10 hours sitting, and he didn't do much exercise either. The pain did not improve with paracetamol, and we didn't observe arthritis, enthesitis, dactylitis, skin lesions, changes in bowel habits, red eyes, photosensitivity, muscle weakness. So quite a thorough medical history. So what should stand out to us from this medical history? Well, that lower back pain with inflammatory characteristics, which improves with movement and doesn't ease with rest. Everything that Andres has already mentioned. In addition, it disrupts nighttime sleep, and it's typical for it to occur in the second half of the night. It's also associated with morning stiffness. With all this, in a man under 45 years old, we should consider the possibility that we are dealing with a spondyloarthritis. Exactly. We examined him. There were no abnormalities, except that hip mobility was indeed limited in external and internal rotation, as well as inflection and extension. The Faber test was clearly positive bilaterally, and he also experienced pain when we palpated the sacrum. We suspect axial spondyloarthritis. What do? Well, we order a full blood test, a urine test, a chest x-ray, spinal x-rays covering the 3 segments, cervical, thoracic, and lumbar, along with imaging of the pelvis or sacroiliac joints and of the hands and feet. We've made the diagnosis. Well, clinically, it seems to be axial spondyloarthritis. What do? Well, we follow the algorithm that the 2022 guidelines have proposed. First, we tell him not to smoke again, encourage him to do supervised physical exercise, educate him, explain what the disease involves, and we start him on anti-inflammatory medication. We prescribed celecoxib and scheduled a follow-up in 2 to 4 weeks. We saw him a month later. He told us that he hadn't improved at all with the anti-inflammatories. The pain symptoms in the lower back persisted, and the blood tests didn't show anything significant. However, he did test positive for HLA-B27. The urine analysis was also normal, and the x-rays of the hands and chest were normal. However, in the cervical, thoracic, lumbar spine, and sacroiliac joints, even the feet showed some abnormalities, which we're going to look at now. This x-ray of the cervical spine does show some squaring of the vertebral bodies, which is what we observed. The thoracic spine also shows the same findings as the lumbar spine, some ankylosis and the bamboo spine's appearance that Esther described so well, along with more squaring of the vertebrae. And also, just as a kind of illustrative example, I included the image of the dagger sign, which Esther also mentioned, representing the calcification of the interspinous and supraspinous ligaments, along with the calcification of the sacroiliac joints, which we'll look at now. Here, we don't see them. Why? Because they already have grade 4 sacroiliitis. In the foot x-rays, we can very clearly see erosions in the left foot at the second metatarsal. And therefore, as a result, we diagnosed this man with bilateral grade 4 sacroiliitis thanks to the sacroiliac joint x-ray. So, ultimately, let's move on to the classification criteria. In conclusion, this patient tells us that he has had lower back pain for more than 3 months and that it started before the age of 45. We found sacroiliitis in the imaging branch and among the characteristics of spondyloarthritis, we found inflammatory lower back pain, and in addition, he tested positive for B27. All of these factors, therefore, certainly lead us to diagnose him with axial spondyloarthritis. And now, what treatment should we give him? In theory, we have administered a dose of anti-inflammatories. Now, he would be, at this point in time, due for another cycle, but with a patient who already has axial symptoms, lower back pain. As you might expect, we actually skipped that step and went straight to prescribing a biologic. The patient is currently doing well, though with some lingering effects. So to conclude this presentation, in summary, the etiology of axial spondyloarthritis is still not yet fully understood, although the interleukin 23/17 axis and HLA-B27 are of particular interest. Axial spondyloarthritis is divided into radiographic or classic axial spondyloarthritis and non-radiographic, depending on whether there are changes in the sacroiliac joints visible on a plain X-ray or not. We define inflammatory low back pain as the presence of 4 or more of the following characteristics. Onset before the age of 40, improvement with exercise, no improvement with rest, nighttime pain, and insidious onset. The presence of sacroiliitis on an MRI is not diagnostic of spondyloarthritis. This finding, along with clinical symptoms and compatible lab tests, is what allows us to suspect the presence of axial spondyloarthritis. The first imaging test to perform when spondyloarthritis is typically suspected is an X-ray of the sacroiliac joints and the lumbar spine. And if this indeed confirms the diagnosis, no further complementary tests would generally be necessary. Routine MRI scans are not typically indicated on a regular basis, only if there is poor disease progression or to make therapeutic decisions in the context of patient care. In general, they are recommended or necessary. Treatment will be based on both non-pharmacological measures, such as physical exercise and physiotherapy, and pharmacological measures, with anti-inflammatory drugs being the first line. If there is no response to 2 full-dose courses of anti-inflammatory treatment, it is necessary to reassess whether there are axial symptoms in order to initiate a biologic DMARD or a JAK inhibitor. And in the presence of extra-articular symptoms, if we have uveitis and inflammatory bowel disease, a monoclonal antibody against TNF is preferred, whereas if it is psoriasis, an interleukin-17 inhibitor is preferred. When it comes to discontinuing treatment, we prefer to space out the doses rather than stopping it completely. That is, the latter is associated with disease flare-ups.